Ladies and gentlemen, today we're going to listen to a talk about iron monitoring in thalassemia. This is a very important, a very basic talk because, as you know, early detection of iron overload, early detection of iron toxicity will help to direct treatment so that cell damage, tissue damage will be minimized, thereby reducing complications and saving lives. To talk about this subject, we have with us Dr. Paul Telfer, who is a consultant hematologist at the Barts Hospital in London, in the United Kingdom, and a senior lecturer in hematology at Queen Mary's University Hospital in London. So, ladies and gentlemen, I leave you with Paul because he's well known to all of us, in fact, as an expert in the management of hemoglobin disorders. Paul.
Thank you very much, Mike, and thank you to Thalassaemia International Federation for organising this lecture series and for inviting me to talk. As you say, this is a very important and basic subject, and I hope I'll be able to cover this in a simple way and a practical way so that when you're managing thalassemia, both transfusion dependent and non-transfusion dependent, this will be helpful. I'm hoping that I'm going to be able to advance my slides. I'm a bit worried that I might not be able to. Rawad might need to help me. So in the talk, I'm just going to briefly talk about the pathology of transfusion iron and iron overload in non-transfusion thalassemia. I think this has also been covered in another talk. I'm going to talk about some of the methods currently in clinical practice for assessing transfusion iron overload, and some of the methods that are being used more in the research setting, and why these may not be appropriate for the clinical setting at the moment. And I want to make some comments about using these methods in low resource settings, particularly in the developing world, where many people with thalassemia live. So there'll be some practical suggestions and then some conclusions. And following that, I'm very happy to answer questions. So Rawad, I'm having trouble in advancing the slides on this. Oh, there you go. So you might need to do this for me as we go along. Well, the basic problem is that when we give a transfusion, we're giving a certain amount of iron. Iron is part of the hemoglobin molecule, and the body doesn't have a method for getting rid of extra iron that comes in with the blood. And it's quite easy to calculate how much additional iron is accumulated in the body with each transfusion. And this equates to somewhere between 0.3 and 0.5 milligrams of iron per kilogram per day, depending on the size and depending on the transfusion intensity. So this is iron that it gradually accumulates in somebody on regular transfusion. In the case of non-transfusion dependent thalassemia, the pathology is slightly different. Next slide, please. Now, what are the consequences of this iron overload? Well, in the early stages, and Rawad, if you could just, I think there are about 2 or 3, if we could just advance that so that we've got the full slide there rather than, that's brilliant, thank you. So in the early stages of a transfusion program, let's say in a child who's just starting on transfusion, the body's natural means of sequestering, of transporting and sequestering iron are fully functional, so that the transferrin, the iron transport protein, is not saturated, and the function of these body mechanisms is to transfer iron to the tissues, but also to transfer it in a way that's not toxic. And it's only once transferrin is fully saturated that you start to develop the toxic effects due to non-transferrin bound iron, which I will come back to. Iron in its non-bound form is quite reactive. It's a redox reactive element, and with suitable catalysts and in suitable circumstances and conditions within the body, within the cell, it can participate in the formation of free radicals, and this is assumed to be the method or the mechanism by which damage occurs. And as you know, this damage progressively occurs, affecting the heart, and then the endocrine glands and the liver and other tissues of the body. And the heart is the main source of the severe clinical consequences, but also endocrine damage and liver damage, etc. Next slide, please. So in an ideal world and theoretically, what we should be measuring is this non-transferrin bound iron. And this has been an aim for many years to actually measure the redox active toxic form of iron. But I have to say that it's not something that is actually possible and validated at present, although it is used in the research setting, and I'll come back to that a little bit. And it's important to understand this terminology. So non-transferrin bound iron consists of various forms of iron which are not bound to transferrin, which are potentially toxic. And it appears that iron can be bound to other other ligands apart from transferrin in the plasma. And these are predominantly albumin and citrate, but perhaps other things as well. And it's believed that these ligand forms of iron are probably not that active, but there is another form of non-transferrin bound iron where it's not particularly bound to these ligands, or not tightly bound to these ligands, and we call this labile plasma iron. And this form of iron is chelatable, but it is also free to participate in these redox reactions that I mentioned, and thereby causing toxicity through the generation of toxic free radicals. So ultimately, we believe that it's the labile plasma iron component that's probably the toxic form that, if it could be measured and if it could be monitored, would be most valuable. But at the moment, we're not able to do that in a validated way. Next slide. So let's go back a bit and think about what we can do to measure iron. And I'd like to start with something that is really obvious, but is something that actually is rarely done, but is quite important in assessing for each patient their a degree of iron loading and their requirement for chelation. And this is simply a calculation of the transfusional iron input based on the volume of blood and the hematocrit of blood and the patient's weight. And if you look in the TIF guidelines, I did actually have a look in the 3rd edition, which is the most recent edition, and I couldn't find this guide, but it's certainly there in the 2nd edition. But I would recommend it. And it's just a way of calculating on an annual basis how much iron is given to the patient through the transfusions. And essentially what you do is you record the volume of each transfusion. You have a knowledge of the hematocrit of the blood, so that you know the volume of the pure red cells. You make a calculation of the total pure red cells infused over the year. You divide that by the average patient weight over the year to get the mils of pure red cells per kilogram. And then you can convert that into iron by multiplying by a factor of 1.08, which would be the milligrams of iron per mil of pure red cells. And then you can divide that by 365 to get the milligrams per kilogram per day. And if you remember my previous slide, I quoted a figure of somewhere between 0.3 and 0.5 milligrams per kilogram per day of iron infused with the blood, which would be a typical transfusion requirement. And it's quite important for each patient to have an idea of whether they're a high or low transfusion requiring patient. And this will be important in deciding how much chelation they need. And so this should be a matter, of course, for each of your patients to, on an annual basis, to calculate their blood transfusion volume and their iron loading on an annual basis. Next slide. Well, what about the blood tests that we can use to monitor iron? There are a number that are widely available in health service and private laboratories that could be of value. And I've mentioned the NTBI and the labile plasma ion, which are not yet validated, and so I'm not going to recommend those. Serum ferritin I'm going to talk about, and a little bit about transferrin saturation as well, which does have a certain value. Serum iron by itself is not very useful. It fluctuates during the day, and it is also sensitive to other factors affecting the patient, such as if there's an inflammatory condition, an infection. So a simple measurement of serum iron is not useful in monitoring transfusion iron overload. Next slide. Well, ferritin, you'll all know, is a blood test that is widely available and has been used for many years as, I would say, the primary means of monitoring iron overload, and particularly monitoring the trend in ferritin over time. And although there are possible problems with the use of ferritin, which I'll list in just a second, we know from various studies, some of them quite old, and mostly relating to iron chelation with desferrioxamine in the early years of thalassemia treatment, whereby values of serum ferritin over time have been associated with clinical outcomes. And this is one study that's often quoted by Oliveri, based on a cohort studied over 15 years or so in America. And essentially this shows that if you maintain the serum ferritin below 2,500, then it's protective against cardiac disease and cardiac death. You remember the heart is the main feared organ in terms of iron toxicity and death in thalassemia. A serum ferritin level over 2,500, either relatively frequent or frequent, is associated with an increased risk of cardiac outcomes in the long term. So this is an early study, and although it's important, I think we have to think about these figures and outcomes in a more sophisticated way. So a level of 2,500 is really too high, and most would now consider a level of 1,000 or somewhere between 500 and 1,000 micrograms per litre as, say, a more appropriate and achievable target for maintaining the serum ferritin to protect against cardiac disease and for other complications of thalassemia in the longer term. And a level of 2,000, 2,500 is really too high. Next slide, please. So ferritin is relatively cheap and available in most laboratories. Interpretation is required, and certainly if you're just looking at a single ferritin level, this can fluctuate from month to month or from day to day, and is sensitive to other factors apart from just the level of iron. And in particular, it's an acute phase protein which increases with intercurrent infection and inflammation. And in most of our experience, we have patients where the serum ferritin, we know, actually doesn't reflect the iron levels, both in terms of liver iron, cardiac iron, or indeed in terms of their chelator history and their clinical course over time. So there are patients who appear to have a long-term increased ferritin where they're probably not at such an increased risk of cardiac disease in the long term. And conversely, there are some patients who seem to have a relatively low ferritin who do get into trouble. So although it's a useful test and a readily available test, it has to be interpreted with caution. And I think the most important thing is that the trend over time that's really important to monitor and use. And if you look at the guidelines for use of the newer chelating agents, particularly XJADE or deferocyrox, serum ferritin is really the most common, or the recommended indicator for making adjustments in dosage of XJADE. So for instance, if the level of ferritin goes below 500, this is the guidance is either to stop the XJADE or to reduce or modify the dose. So ferritin, because it's easily available and because it's been used in the studies, is still a very important part of the methodology for monitoring iron, and I would certainly advise using it, but my advice would be to use it alongside the other methodologies which I'm going to talk to you about now. So let's go on to the next slide. So we're going to talk about magnetic resonance imaging. So just one slide back. This is just to reiterate what I've been telling you about the measurement of non-transferrin bound iron and labile plasma iron. There are plenty of research papers where it's been used and where it's provided, particularly LPI, important information about what's going on with chelation and toxicity. But I think this paper is particularly helpful in demonstrating the variety of different methods that can be used, and the variation in the results and in the interpretation and the difficulty in standardizing these methodologies. So based on this paper and other papers, the advice really is that at the moment LPI and NTBI shouldn't really be used in routine clinical practice. Next slide. Next slide. So let's talk now about magnetic resonance imaging, and I'm going to start with imaging of the heart. And this, as we've said, the heart is the principal target organ in terms of morbidity and mortality in thalassemia. Cardiac disease is still the commonest cause of death, and this relates to cardiac iron overload. And with the introduction of MRI techniques, in particular this T2 star parameter, which was developed as a method for quantitating myocardial iron, and also for assessing cardiac function accurately, assessing left ventricular diastolic and systolic volumes, ejection fraction, as well as the amount of iron in the myocardium. And this is a methodology that is applicable on any scanner, providing that the right methodology is used and providing the scanner has been validated. And this enables, as I've said, a measurement of the myocardial iron. You can see on the right there that colored picture with the ring or the oval of black. This is showing the segment of the interventricular septum, which is sampled. And because iron has paramagnetic properties, it interferes with the magnetic field in a way that can be quantitated, and using this specific parameter seems to be most sensitive to the measurement of relatively low concentration of iron within the myocardium, and is applicable in an organ which is moving all the time, which is beating over a defined cycle. Next slide, please. And this has been validated in a number of ways. There's a study, which I'm not showing in this talk, where post-mortem hearts have been scanned to actually do or confirm the calibration, where the heart muscle has been analyzed by chemical methods for iron concentration and then compared with the MRI methodology. But it's also been validated in terms of clinical outcomes. And this is a very important study that was published about 10 years ago now, where a number of patients in the UK were scanned and their T2 star was measured, and then they were followed over a period of time. And there was a, if you like, a dose-dependent risk of clinical cardiac disease and death. And this not only established the clinical validity of measuring myocardial iron by T2 star, but also the range of values which are of clinical importance. Now, we use a measure of above 20 milliseconds as indicating no myocardial iron, and a level of between 10 and 20 as moderate myocardial iron. And you can see that below 10 milliseconds, the risk of cardiac disease becomes more apparent. And certainly below 6, there is a substantial risk over the subsequent year of developing arrhythmias, cardiac failure, or death. So a level of below 6 milliseconds is really very worrying and an indicator of the need to modify iron chelation urgently. In fact, any myocardial iron would be an indicator that there's a need to concentrate on reducing and getting rid of the myocardial iron. And there are various chelating regimes that might be used to do this, which I won't talk about today. This will be covered in another talk. Next slide, please. Robert, if you could just move on, because there are just 2 or 3. I think that's fine. So just one further point about this, which is that, of course, MRIs are available throughout the world, including developing countries, although in developing countries they may only be available to a small proportion of clinicians and patients who can afford to undertake the scan. A colleague of mine working at Barts, Professor James Moon, with Malcolm Walker and others whose names you'll be familiar with, have been looking at how this methodology might be modified to make it more available in developing countries where there are large numbers of patients and large clinics. And they've validated a slightly different parameter, T1, which will also quantitate myocardial iron, but it will do it much quicker and will give a map of the myocardium. So you can actually see on a colour picture, a bit like what I showed on that previous slide, where the iron is. And it will also give not so much detail about or precision, but will tell you whether there is some moderate or severe myocardial iron, which is really more or less what you need in making clinical decisions. And this scan can be done cheaply and quickly. It takes less than 10 minutes. So you could actually scan a large number of patients, as they did in this study in Bangkok, and they've also done in India. So I think going forward, there may be an opportunity to make myocardial T2 star available to reduce the risk of cardiac disease in patients in the developing world where MRI may not be available in the standard clinics for the majority of patients. Next slide. We'll move on now to measuring iron in the liver by MRI. And the reason why this is important is because, first of all, because the liver is a site of iron toxicity. As you know, there's a risk over time of developing cirrhosis and hepatocellular carcinoma as a complication of liver iron overload. But also, we know from various studies that the amount of iron in the liver is a good reflection of total body iron, so that fluctuations or monitoring of liver iron is a very good way of monitoring the success of chelation in reducing total body iron stores. And so liver iron is really important and is an additional to myocardial iron. You can't do one or the other. You really do need to do both. For the reasons that I've mentioned, and the fact that myocardial iron doesn't always correlate or reflect the liver iron store. But it is very important to use a methodology that is validated and quality assured. And there is a concern that implementing a whole range of different parameters and techniques for measuring liver iron by MRI may result in getting different results, and results that may not be accurate or reproducible. And I'd like to spend just 2 or 3 minutes describing a methodology that has been well validated and has been shown to be robust across different scanners and is amenable to quality assurance, and is useful for comparing in different clinics and in different research studies and so forth. And this is the methodology called FerriScan, or R2 measurement of liver iron. And this has been through a validation program which crucially has involved calibrating against liver iron as measured chemically through liver biopsy, and then quality assured. So whatever method is used, it has to go through these stages of validation. If we could go on to the next slide, please. Rawad? Yeah, so this is the validation of FerriScan, which involved liver biopsies. And what you see here is the biopsy liver iron concentration on the x-axis, and the liver iron as assessed and quantitated using the MRI, the R2 MRI technology on the y-axis. And you can see that there is a strong correlation, and you can see in their studies a good agreement between the methods. Of course, liver biopsy and chemical quantitation has its own problems, and as a result of that, you're not going to be able to have a perfectly satisfactory calibration, because even if you take a biopsy and measure the liver iron by chemical concentration, this depends on where you're sampling within the liver, on the methodology of the laboratory method for chemical analysis. But I think most would agree that certainly over the range of values that are useful clinically, let's say up to 20 milligrams per gram dry weight, there is a relatively good linear relationship between liver iron and the MR technology. And this has been validated across a large number of patients in different sites across the world. Next slide, please. Now, another method is using T2 star or R2 star to measure liver iron. And this has been used in a number of studies and is also used in a number of clinics. However, there is some concern about doing this because depending on the scanner that you use and depending on the precise details of the software, of the sequence, the MRI sequences, you get different results. And this has been illustrated through showing the R2 star and the liver iron calibration from a number of studies using a number of different scanners. And you can see that the actual R2 star relates to the liver iron concentration for each individual study, but if you compare the different studies, there's quite a wide range, so that it's not clear at the moment that R2 star is transferable from one scanner to another. And I think we need to think perhaps internationally about this if we're going to use R2 star across a lot of different sites. So my conclusion is that probably the best thing, if possible, is to use FerriScan for liver iron quantitation at the moment for robustness. However, there is a problem, particularly in the developing world, in that there is a significant cost involved in doing FeriScan. You have to do the scan, and then you have to send the MR parameters across to the company that actually provides the result for you, and that entails a cost as well. So there are a number of issues around liver iron concentration that need to be thought about, and I think that perhaps we do need a little bit more of an international consensus about that. Next slide, please. There have been a number of other studies where other organs have been scanned and iron concentration measured using various methodologies, mostly R2 star, and notably pancreatic iron and pituitary iron. Of course, the pancreas and pituitary are other organs that are affected by iron overload in thalassaemia. These are very interesting and have provided some important data on what happens to the pancreas and how it correlates with iron in other parts of the body, particularly the heart. It does seem as though the pancreas loads with iron prior to myocardial loading, and may be an early indicator of the risk of cardiac iron, as well as perhaps predicting the onset of diabetes. And pituitary iron is related to pituitary failure and pituitary damage from iron overload. And it's also useful in scanning the pituitary because it seems that if the pituitary volume is significantly reduced, that seems to indicate irreversible pituitary damage as a result of iron overload. However, both of these methods and others, again, have not been fully validated. And it's not clear that they provide vital clinical information to guide treatment beyond the methods that I described at the beginning of this talk. So I wouldn't advise using pituitary and pancreatic iron in routine clinical use. And I think what would be more important is to ensure good methodology for myocardial and liver iron if you're building up and developing a service. Next slide, please. So practical guidance in monitoring iron overload in transfusion-dependent thalassaemia. We've mentioned, we've got 4 different methods, and I think we need all of these. Transfusional iron intake using that calculation I showed you at the beginning of the talk. Serum ferritin, do you need to do this as frequently as monthly? Probably not, although certainly in high resource settings, when we do our pre-transfusion compatibility testing, we generally take blood for ferritin as a routine. So the patients basically get it every time they come up for their blood test. And I guess the more frequently that you measure the ferritin, the better trend you're going to get. But it should be measured at least every 3 months. And I think it's reasonable to aim for a level between 500 and 1,000 as an ideal for suitable measurement of iron overload. The liver iron should be done every 1 to 2 years. In a patient who's very well chelated with a low ferritin, it may not be necessary even as frequently as that. And the target level is 3 to 7 milligrams per gram dry weight. Myocardial iron, this will depend, the frequency will depend on the patient and on their whether there is myocardial iron there or not. So for a patient who persistently doesn't show any myocardial iron, so with a T2 star above 20 milliseconds, It's probably not necessary to do the scan every year, and every 2 years will be quite okay. But for a patient who's got significant myocardial iron, let's say with the level below 6 milliseconds, where you are intensifying the iron chelation to improve the situation, this would need to be done more frequently. There's probably no point in doing it more frequently than 6 monthly. And in the studies that were done looking at rapid de-ironing of the myocardium, there weren't really any significant changes that occurred in a time duration less than 6 months. So I would recommend for a severely iron overloaded patient who's requiring intensive chelation to de-iron the myocardium, 6 monthly would be appropriate. Next slide, please. One other practical suggestion is to develop a transfusion spreadsheet, and this is what we use in my service, and we use also for monitoring patients who are treated in other centres, where we review them perhaps once a year or twice a year. And it's basically just a simple Excel spreadsheet, but it contains useful information and instructions for the transfusion unit staff on how much blood to give and what chelating regime they're on. But it also enables you to record their pre-transfusion hemoglobin level, the amount of blood, the volume of blood that they've given at each transfusion, their weight and their ferritin, and also to monitor for the side effects of iron chelators, for instance, neutrophils if they're taking deferriprone. At the end of the year, this Excel spreadsheet will very simply calculate the average of their pre-transfusion hemoglobin. It will sum the volume of blood given and calculate the milligrams per kilogram of iron given per day, or accumulated per day. And will also give you an average ferritin. So we find these very useful as a means of monitoring the patients on an annual basis. And it's really very, very easy to design a spreadsheet like this. So I would recommend that. Next slide. What about non-transfusion dependent thalassemia? Next slide. So these are patients who are not developing iron overload as a result of transfusion, but as a result of the increased iron absorption, which is deregulated in non-transfusion dependent thalassemia. And the pathology behind that I won't talk about today, but is I'm sure will be covered in another talk. So the iron accumulates in non-transfusion dependent thalassemia much more slowly, but over the years and decades, it can accumulate to the extent to cause significant damage. And as you know, there's a risk of cirrhosis, hepatocellular carcinoma, and rarely cardiac disease in these patients. And there are 1 or 2 points to remember. First of all, that the serum ferritin doesn't have quite the same relationship to iron overload as it does with transfusion-dependent thalassemia. And in particular, it seems that the ferritin for a given level of liver iron seems to be lower. So the parameters in terms of serum ferritin, if you don't have a liver iron concentration, for deciding on when to start chelation and how much chelation to give, would be slightly different with non-transfusion dependent thalassemia. And I know that there's a question on the blog about this, which I can maybe answer afterwards. Next slide, please. And similarly, there are differences in the myocardial iron loading, and it's actually quite rare to develop significant myocardial iron overload. But it may well occur in patients who do get intermittently transfused, and particularly those who are in the older age range, perhaps over the age of 50. So it is important to, even though the risk seems to be less of iron-induced cardiac damage, you still have to bear it in mind, and at some stage these patients will require some assessment of myocardial iron loading. Next slide, please. So that's just a summary of those points I've been making. I think, again, liver iron concentration is probably the most useful, if you can do it, for monitoring iron in non-transfusion dependent thalassemia. And we come back to this issue about using a validated methodology for liver iron concentration. And again, I would recommend, at present, I would recommend using FerriScan if you can. Or making some attempt to validate T2 star or R2 star if that's what you're using. Next slide. So in the same way that I gave some guidance on transfusion-dependent thalassemia, this would be the suggestion for non-transfusion dependent thalassemia. Serum ferritin doesn't need to be monitored so frequently, but most of these patients will be having a clinical review every 6 months to every year, and that should include serum ferritin. Liver iron concentration should be measured perhaps every 2 to 5 years, and in those where you've done a liver iron and the level is higher and they're on a chelating regime, then the liver iron concentration would need to be, and the ferritin would need to be measured more frequently than that, perhaps every year for liver iron. Myocardial iron, not so frequent, but each patient should at least have a single scan at a particular time point, perhaps at the age of 15 as a starter, and then perhaps every 5 to 10 years. I don't think there's any particular consensus about that, but I think there's a principle that can be used to make a decision for your own service and your own clinic. Next slide. So in conclusion, I think regular and systematic monitoring of iron overload is needed for both transfusion-dependent thalassemia and non-transfusion dependent thalassemia. And this will enable an assessment of the risk of toxicity from iron, and will be important in guiding decisions about starting and modifying iron chelation treatment. I think the long-term documentation of the results of iron monitoring should be done in a good way, and in a format that allows monitoring of trends. And this concept of the trends, both in ferritin and in the MRI methods, is really important, so that you can very easily look through the patient's results over a number of years to see what's happening. And these spreadsheets that I showed you are one way of doing that. I think for MRI methodology, it's important the methods are properly validated and quality assured, but it's important that we find ways in which that can be done, and so that MRI techniques can be made available in low resource settings in the developing world. But certainly in low resource settings, there will need to be more reliance on simple blood markers such as serum ferritin. And for most purposes, ferritin can be used alone, even though some detail and some important information will be missed. If there is nothing else available, then certainly regular monitoring of ferritin and the trends in serum ferritin will be extremely useful. I'd like to thank my team, patients and staff, Barts Health, Royal London Hospital, and also 1 or 2 clinicians who've contributed a little bit to this talk, including Professor James Moon, who's been doing the T1 cardiac studies, and Professor Tim St. Pierre, who has developed the resonance health FerriScan methodology and has done a lot of thought about validating liver iron concentration methodology by MRI. So thank you to those 2.
Talk, all of us learned a lot, and you touched on some points that a lot of clinicians are a bit confused on whether to use and how to use. I'm sure you touched very well the point of the low resource countries that our major problem for decades now is that the greatest majority of our global patient community does not have access to the appropriate monitoring. And the other concern that we have is that even those that have access and they pay, because most of the healthcare systems are still out-of-pocket based principle, let's say. But even though there is a lot of exploitation on the use of the MRI and what kind of calibration they are using, so these are challenges that we are facing as a patient-oriented organization that we are trying to address almost on a continual basis. Thank you so much, and let's see if there are any questions.
Do you see the questions?
Let's have a look. I can see 3 questions.
Okay.
Yes.
So I'll start at the top here. Excuse me. So this Sufyan on transfusion since 6 months of age, my serum ferritin is 2,800. Is this low or high? Thanks, Sufyan. Thanks for your question. And yes, this is an important topic which I mentioned, how you evaluate a serum ferritin. So 2,800 is just a single figure there, and I'd want to know a little bit more about the trend. So whether this is just a one-off, or whether that's been a consistent, or the readings have always been within that range. In which case, I would say that that is too high, and that more could be done in terms of iron chelation to reduce the ferritin. And I think you should be attempting, through collaboration with your doctor, discussing the type of iron chelation that you're taking and how it can be modified to get that level down. I would try and aim over time, set yourself a target. I did mention the figure of 1,500 to 1,000, but that's going to take time. And I would set yourself maybe a target of, first of all, getting it down to 2,000, then 1,500 over time. But you need to talk with your clinician, with your doctor, about how you're going to do that. It's not just the treatment, it's also making sure that you do that treatment on a regular basis, day by day by day, and don't miss doses, and then you'll get there.
Question number 2.
That's you as well, Sophia. Can iron overload cause fertility? I think you mean, can it impair fertility, or can it cause fertility problems in male?
Can impair, that's the question, yes.
Yeah. So the answer is yes, it can do, but it's not inevitable. And again, I'm sure that will be covered in another talk in this series. Is that not right, Andrula, Mike?
Yes, it is, on the endocrine side.
Yeah. Okay. So I'd rather leave that to the endocrine experts to give you some answers on that, okay? Now the next one, an anonymous attendee, pediatric patient who's 15 years old, started combination therapy, so subcut desferal and X-Jade, dose optimized her weight. Recent ferroscan shows a reduction in cardiac iron, but still present. Serum ferritin recently shows a slight upward trend over 5,500. Compliance issue has been addressed. How do we effectively monitor and treat this iron overload? Okay, so that's a number of comments there. And I'm not sure whether the attendee can actually talk real time to me, but first of all, so this is a young person, 15 years old, on a slightly, a good choice in a way, a combination treatment with desferal and X-Jade, although this is one of the combinations of iron chelation that are often used, but have to be used with some expertise involved because it's not one of the licensed ones, but I'm not saying it's not the right thing to do. And dose optimize, that's great. And it's good to see that there is a ferrous scan, but cardiac iron is not normally, ferrous scan is normally used for measuring liver iron. And I wonder whether you're actually talking about cardiac MRI, T2 star, or a ferrous scan certainly does offer myocardial iron as well. But I think that it's good that the cardiac iron is being reduced, but I would like to know what the liver iron is, because that is also going to be very important in making adjustments to the chelation, because just based on the ferritin, a level of 5,000 is quite high. If you remember, I said levels over 2,500 in those early papers were associated with increased risk of problems. And there'd be a fair way to go to get the level down. But I also said that sometimes the ferritin doesn't fully reflect body iron, and that if you are able to do a liver iron preferably by ferrous scan, then that would be further information that would be helpful. So your question is, how do we effectively monitor and treat the iron overload? And I think the first thing is about monitoring. And what I would like to see is the longer term trend in the ferritin. And I would like to see what kind of MR results you have and what kind of methodology you're using in order to give further advice about this. But if we're just looking at the ferritin, then you need to monitor the ferritin on at least a 3-monthly basis and look for a progressive decrease in ferritin. You don't need to get it down overnight, and in fact that's not going to happen. But I would, again, like in the previous question, I would aim for a progressive reduction in ferritin. If you're using that combination, that's fine, but you're looking to and set a target of reducing the ferritin, let's say down to 4,000, 3,000 gradually, and really work on compliance, making sure that the chelation is being taken effectively on a day-by-day basis. I'm sorry, I can't give any more detail without knowing a little bit more, any more advice without having a bit more detail, but perhaps if you want to maybe put a bit more in, then I can.
They can even send us more comprehensive information, and we'll be sharing with Dr. Telfer. But in conclusion, Dr. Telfer, you may sort of conclude that the best monitoring at the point is to very closely monitor the ferritin levels.
Yes, yes. And I think also just to clarify what kind of scans are being done there and what the results are. It looks as though this patient does have access to MR scanning.
Yeah, we would be very happy if they share it with Tiff, and then we'll share it with Dr. Telfer more comprehensive.
Okay. The next one is next question, very important about during this period of coronavirus, the coronavirus epidemic, in terms of the frequency of testing. Well, that's so I assume that your patients are still having their transfusions, and if they're still having their transfusions, then they are going to have to come up for their blood tests. So there should be no need to change the frequency of testing using the blood tests, but there certainly are some issues around the safety of doing MRI scans. And we've certainly had these issues as well locally in London, where during the course of the epidemic, we were actually not doing scans for about 3 months. And we had to have a guarantee that the scanners were being properly decontaminated and made safe going from patient to patient. So we have started doing scans again now. There is a backlog, but this is an important consideration in terms of patient safety, because those scanners will be scanning a lot of different patients for various reasons, but potentially some of them for coronavirus indications. So there is potential risk of transmitting coronavirus through sitting in a scanner, although I wouldn't want to raise an undue alarm, and I'm not aware of any documented cases where that's actually happened, but I'm not entirely familiar with whether anything has been reported on that. So the answer is, my recommendation is that if you can ensure that the scanning can be done in a COVID safe way, and that your scanning department is open for scans at the moment, then that would be acceptable. But if not, then I would rely for the time being over, hopefully the coronavirus situation won't be indefinite, and you can certainly rely on blood tests for a few months. Next question. I'm facing bad digestive problems with ferroprox, dizziness. Okay, so that's related. I think that's more relating to side effects of iron chelator drugs, and I think probably that's a question that maybe I could answer offline with this patient, Abdul. If that's all right, maybe we can communicate on email.
Yeah, but can you just comment on the fact that, you know, he's been taking 9 tablets, but now the ferroprox is being sort of upgraded with less dosage? Yeah, ferroprox.
Yes, well, I mean, to be honest, even in the UK, we're mostly using the 500 milligram tablets. Rather than the, I think they have a 2 gram formulation.
They have a 2 gram formulation.
Yeah. So that would certainly be worth looking at. The other formulation, there is a liquid formulation, and that might be worth looking at as well, although it would be a fair volume of liquid you'd need to use.
So please contact Dr. Telfer,
yeah.
And you can have a more comprehensive discussion.
Yeah. Okay, next one. What's the best method for calculating transfusion for thalassaemia? Target hemoglobin or reference ranges using mils per kilogram. Okay, so I think that's more about how much blood you need to give per transfusion episode, depending on what the hemoglobin level is, the pre-transfusion hemoglobin. So that's slightly off the topic, but maybe again that's something I can share. So I mean, we have an algorithm which is actually based on, for the children, is based on mils per kilogram, based on their pre-transfusion hemoglobin, which works quite well with us. But there is also a method for doing it based on the incremental change in hemoglobin that you want. Mm-hmm. What's the timeline for improving ferritin trends in patients who come with very elevated ferritin levels up to 10,000? Well, above a certain level, the actual value of ferritin is quite difficult to interpret, because it becomes the level is also related to actual direct toxicity in the liver. However, it's going to take time to get the level down, and I think that realistically, it's probably, as a rule of thumb, I would expect that to see a trend in serum ferritins based on 3 monthly testing, and I would want to see at least a reduction of 1,000 per year, maybe more than that, but again it will depend on the particular clinical circumstance there, because if the level is so high, that would suggest there may be other problems relating to the heart, and you might want to use a very intensive chelating regime, for instance a combination of continuous intravenous desferrioxamine and ferroprox, or deferoprone, in which case you might see a more rapid reduction in ferritin. That would depend on the individual patient. Pediatrician from Algeria, when you decide to stop iron chelation, serum ferritin below 500. Okay, so that's an important question, and we've had quite a lot of debate about this. I think that if we're talking about transfusion-dependent thalassaemia, I think many of us feel that it's probably best not to stop chelation completely, because the patient is going to be continuing to iron load through regular transfusions. And so even if the ferritin level is around that low level of 500, I think many of us would consider that chelation should continue, but you would want to adjust the dose and to minimize the dose to avoid adverse effects of the chelator drugs. That's the main problem, that if you have a low level of iron overload, then you might put the patient at higher risk of chelator toxicity. And if you look at the XJADE product summary, they actually recommend either stopping or modifying the dose if the level's below 500. So if in those circumstances, I would reduce the dose. And with XJADE, for instance, you can reduce the dose quite substantially while continuing to provide iron chelation. So I have 1 or 2 patients who are just on the lowest tablet dose of 90 milligrams. And we do have some patients who have had very low ferritins for many years and are on a chelating regime which has been stable over that time, and we monitor carefully for toxicity and ensure that there is no toxicity. And so we continue their chelation with ferritin levels between, let's say, 100 and 500, monitoring carefully for toxicity. So I think the question, so I think my answer would be, I would be reluctant to stop chelation, but I would want, depending on the particular iron chelating drug, I would monitor carefully for toxicities and try to minimize the dose while monitoring to ensure that the ferritin level stays at around that level. Combination of deferoprone and XJADE. Yes, there are studies in the literature, quite small numbers of patients, but that combination of deferoprone and deferocyrox or XJADE is used. We use it, and I think that there's a certain amount of non-validated chelator, iron chelation practice that inevitably happens, given that we now have 3 iron chelator drugs available and different routes of administration, and that we have to find an appropriate regime for each individual patient. So this particular combination is not one that is probably the least well validated at the moment, but has there are some studies that suggest that it might be quite potent and might be quite a good regime, particularly because it avoids any injections with obviously that you require with desferrioxamine. So I would say that there are certain patients who might benefit from this, but if you're using that combination, I would strongly recommend that it is supervised by an expert and that the aims of the treatment are carefully devised, and the monitoring is done carefully to make sure there's no evidence of toxicity. Questions are continuing. Has there been any reports of hair loss with increased XJ doses in patients with eThalassaemia who are on regular transfusion? I'm not aware of that particular complication with XJADE. It's not a commonly reported complication of XJADE treatment. There may be another cause of the hair loss that would need to be discussed with your clinician. What are the risks of continuous IV chelation? Say again, Mike?
Yes. No, it's okay. It's, I was actually going to ask you, when do we stop answering? When do you, are you...
Oh, okay. I don't know. Oh, it's past 2 o'clock, isn't it? There's still a few. I'll get to the end of these ones, okay? So
Okay.
Chanel's will be the last one. What are the risks of continuous IV chelation? What's the longest period of time should IV chelation be administered if ferritin levels are greater than 5,000? So the risks of continuous IV chelation relate not just to the drug, but to the methodology of continuing to give it. And to do continuous IV chelation, you would really need to have an indwelling intravenous line, usually a portacath. And that entails certain risks, for instance, thrombosis and line infection. So there are risks of that. The continuous chelation is not so much giving it over 24 hours, but again, the risks of giving desferrioxamine in somebody whose ferritin levels and total body iron levels are quite low. So it looks as if your ferritin level is over 5,000, the risk of developing chelated toxicity are relatively low. We tend to see these toxicities in patients with low ferritin levels, let's say below 1,000 or below, and where the ferritin level is falling very rapidly. But with desferrioxamine, you have to be on the lookout for auditory toxicity, so pure, or let's say hearing loss, tinnitus, visual problems, loss of color vision, loss of visual acuity. And of course, with desferrioxamine, also the risk of certain infections such as Yersinia and Klebsiella. We have a little patient of 20 months, thalassaemia major, ferritin is 1,200, began transfusion at 6 months. When do we have to begin chelation? Okay, so this is slightly off my topic. And are you having a session on iron chelation, Mike, Andrula?
There's going to be one, yes.
Yeah.
I don't know when.
Okay, because I think this is an important question around initiating iron chelation, and it's probably best to leave that to the session on iron chelation. It's an important question. Chanel, you're the last. How often should MRI T2 star be conducted for a patient with elevated iron levels? So with MRI T2 star, assume you're talking about myocardial or heart iron. And like I said in the talk, if the level is worryingly high, by that I mean a low T2 star, and if you remember in the talk, I was saying if the T2 star is below 10 and particularly below 6 milliseconds, this is worrying, and chelation definitely needs to be intensified. And I would recommend repeating the scan on a 6-monthly level, if you can, just to monitor and make sure that things are going in the right direction. Right, okay.
We do have one more question, if you can please answer.
Yes.
Yeah, if you can, just a second. Yeah, there is a person asking, I have a pediatric patient, 7 years old, who has been following up in our clinic since 3 years. Her ferritin level is still within the same range since admission, 3,000 to 4,000.
Yeah.
And her MRI T2 star shows severe hepatic iron overload.
Yeah.
The question is whether to start her on combination therapy, and what would be better in her case, deferriprol or desferrioxamine.
Well, so this is a common question about iron chelation in somebody who has, I think you said a high level of ferritin. Did you say the T2 star was also high?
Yes. Yeah. Severe hepatic.
Severe, yeah.
Iron overload. And the patient is already on deferrazirox.
Okay, well, I think what I would recommend here, because again, this is really talking about chelation rather than monitoring But I would recommend consulting the TIF guidelines, and if you like, also the UK Thalassaemia Society guidelines, because we put quite a lot of guidelines about how to adjust and the different regimes that you might use depending on different levels of iron loading. But essentially, there are a number of issues here. First of all, if this is a consistent finding of that you're not able to get the levels down, and you've maximized the dose of single therapy, monotherapy, then you would need to, so the options would be to switch to a different chelated drug and maximize that dose. If that's not possible, then to go onto a combination regime. And I would probably recommend the chelator regime combination that has been, for which there is most experience and most published evidence, and which is licensed. And that would be desferrioxamine and deferriprone. Now, not all experts would necessarily agree with that, but deferriprone is licensed for combinations with either XJADE or desferrioxamine, but XJADE or deferocyrox actually isn't licensed as a combination drug at the moment. So although we do use it, those combinations with XJADE, you have to be a bit careful given that it's not actually licensed. And like I said, there is more experience with the combination of desferrioxamine and deferriprone and the different doses that you might use. So that tends to be my first choice. But again, I would recommend consulting the guidelines and perhaps tuning in to a talk about iron chelation through TIF.
I think we've certainly moved away from monitoring and we're starting questions on actual treatment, which is a subject of another meeting.
Yes.
So I have to thank you very much, Paul. This was an excellent talk, and obviously a lot of questions have arisen, and the audience was very keen to understand and listen. So thank you very much indeed, and we'll meet again.
Yeah, and Mike and Rawad, if there are others who would like to ask questions, you can.
Yeah, I will forward them to you directly.
Yeah.
Thank you very much.
Great. Okay. All right. Thanks. Thanks for inviting me.
Thank you.
Bye for now. Have a nice day.
Bye.
Thank you.
Same to you.